African American Legends highlights the accomplishments of blacks in areas as varied as politics, sports, aviation, and health. We will explore how African Americans have succeeded in areas where they had been previously excluded because of segregation, racism, and lack of opportunity. I am your host, Dr. Roscoe C. Brown, Jr., and joining me on today's program is Dr. June Jackson Christmas, a pioneer in the health field and now executive director of the Urban Issues Group, a black think tank. Glad to have you with us today, June.
I'm glad to be here, Roscoe.
You've had a long and distinguished career in health. I won't say how long, but you've been around long enough to observe what has happened to African Americans in health over the past 2 or 3 decades.
Yes.
So how has that picture changed over that time?
Well, unfortunately, I don't think it's changed very much for the better. We're well aware of epidemics such as AIDS that really have had a disproportionate impact on black people, adults, adolescents, and children. So that's one very dramatic thing. Also, a disease that when I was in medical school was on its way out, tuberculosis. That's arisen again, and because black people are disproportionately poor and live in sometimes in housing that is deteriorated, tuberculosis is on the increase, and it's associated also with substance abuse and with other diseases. And then, of course, the one thing that is probably even sadder than the first two that I've mentioned is that black people, like their counterparts in the white society, are getting sick from things, diseases and disorders that they could have prevented.
What are called lifestyle diseases?
Lifestyle, disorders of choice. People say we're blaming the victim, but in these instances, I think we as human beings need a little blame because we're not taking care of ourselves.
Give me an example of 2 or 3 of those lifestyle
think about
diseases.
Lung cancer. It's really on the increase. It's more recently on the increase in black women because we're smoking more. In fact, young black women are the only group in this country where smoking is increasing. Takes a number of years to develop, but lung cancer is increasing. Alcoholism is increasing and all of the problems that it brings about. Hypertension, even though it's not really a question of choice, because there we're talking about stresses that we as people who are suffering a lot of discrimination experience. So it's not a choice, but it's the luck of being born into a country
also,
with a lot of racism.
Too.
And
soul food
all
is not
of the soul
necessarily the most
food,
healthy.
it sure isn't. It'll raise your blood pressure. It'll make you more likely to have a heart disease. Disorders like that. Obesity is very high. If we look in our black communities across the country, and I'm not just talking about women feeling they weigh 15 or 20 pounds too much. I'm talking about the fact that from teenage up, black women are heavier, so much heavier, that they're more likely to get diabetes, more likely to have heart disease, and more likely to have bone problems.
Why do you think that is? It is certainly documented in the literature that there tends to be a higher rate of extreme obesity among black women. Is that genetic? Is that environmental? What is the reason?
Studies are still going on, so the answers are out, but we do know that there are some things that make you less likely to be obese, and one of them is exercise, and the other is diet. Now, we also know heredity plays a role in it, and maybe genetics in the long run, but we're not so sure. Black people, when they're working, I was speaking about the young black women, when they are working, are often working so hard and working 1 or 2 jobs that they don't have time to run around the reservoir a couple of times a day or go to their park and work out. And so exercise for them, a regular intensive exercise, doesn't have a place in their life that much. Now, I know I'm speaking to a man who believes in exercise and has kept it up all his life. That's very important. But so, for one thing, the pattern of exercising and the commitment to it isn't there because we've got a lot of other things to be doing. And then in terms of food, it is a lot more interesting to taste something that's full of salt. That is until...
Salt and sugar.
And sugar. To get used to bland food is something that's not part of our culture. So some of it has to do with our lack of education.
What about the cultural thing I've heard that black men like their women heavy, and the women want to satisfy the black men, so therefore there's not the motivation or the inducement to slim down a little.
One of the things that we're doing at the Urban Issues Group is a study in Brooklyn looking at how people define health and illness. And as we've been putting our heads together and thinking about some of the topics we want to discuss in our focus groups, one of them is, you know, what does it mean to be heavy? What is that part of being sick? I would vouchsafe from groups that I've met in Harlem and people I've worked with that you've got a little point, that you have a point there, that a lot of women do not think that just because I'm weighing 30 pounds more that I'm really unhealthy. That happens to be the way my significant other likes me. But I think that that's only a small part. I think the other part is not knowing the effect it can have on your life.
And what about the extent to which cancer, particularly breast cancer, uterine cancer, prostate cancer, tends to be higher in the African American community? Is that genetic? Is that environmental? Or is that just the lack of early intervention?
Well, a couple of the things that you mentioned, or one of them definitely is higher, and we're not so sure. Cervical cancer seems to be higher in black women, and it may be because when they have early infections, they don't get to the doctor and don't get that treated, and then there's a chronic inflammation. Breast cancer isn't necessarily higher, but what is true is that regardless of social economic status, the course is much more difficult, problematic, and when the person gets to the doctor, it's much more advanced.
Yeah, they don't have early intervention.
They don't get to the doctors early. We don't get there early. And even when we get there, and this is interesting, people are trying to understand this, even a white woman and a black woman in urban areas who get to a doctor with a cancer around the same stage, the course in the black woman is a more difficult course and less likely to turn out well.
Why is that?
Nobody knows. That's something.
What are some conjectures?
Well, one of the conjectures is that with all cancers, that there's a possibility that the element of hope and of anticipation that things are going to turn out all right is a very positive thing. The fewer stresses that you have to have, the more hope that you have, these may influence the body. Maybe it's a production of some kind of hormones, maybe it's a production of something like interferon, we don't know. Something that the body does in its natural state of healing may help some people who have a better attitude toward that disease. So that breast cancer is more advanced. Lung cancer is increasing, it certainly is. So that there is one other disorder that black women have, and here we don't know what it is. Black women have more fibroids. That's the benign, the non-cancerous tumor of the womb. That really seems to be very common in the United States. It's something that we know has occurred over the last 50, 60, 70 years. We don't know why. So one of the things people wonder about is that dietary. So these are all things that where the answers aren't known, and yet I think it's so critical that people become educated to know that, well, I may be at a risk, therefore I better go see my doctor when I'm feeling good.
Well, that gets into Dr. June Jackson Christmas herself. Your role as Commissioner in Mental Hygiene, your role in being in leadership in the American Public Health Association, and now your role in helping to create, along with some of the rest of the black academic community, a group known as the Urban Issues Group, which is conceptualized as a think tank to deal with concerns of African Americans. You are now the executive director.
That's right.
And as a result of this, you are moving, and the organization's moved right into health and healthcare. So could you tell us something about some of the things that are happening in UIG? I happen to know because I'm related to the group as well. But I think
we're very happy to have you as our chair.
It's very important that the community at large understand how serious black scholars look at some of the issues. We'll talk about some of the others later in the program. But let's talk about what UIG is doing in healthcare.
Well, the Urban Issues Group, as you said, was set up as a think tank to a place where black men and women who were in the academic world, who were administrators of city agencies or non-profit groups, or who were people who were active in volunteer roles in their communities in the city could come together and think about critical issues, could hire people to do some research. And the third point was to bring this information before the public, before people were making policy. And last year, when in 1994, that is a while ago, when the raging debate that was on was about healthcare reform, we thought it was very important to bring those issues before people in New York City. And so we had a forum that addressed black healthcare reform and Black New York. And out of that comes our first major publication called Facing Triple Jeopardy. It's about health policy and the health of Black New Yorkers. The reason we're talking about triple jeopardy is that we're, in many instances, victims of discrimination, and we certainly are all victims of a history of discrimination. We are poor disproportionately, and when we get ill, we've got 3 strikes against us. And poverty makes it much harder for people to get health care, and barriers, institutional racism and others, make it harder. What we've done in that volume is, which we want all your viewers to be able to have, that volume is to spell out a review of what had gone on in the last couple of years in health policy nationally, with some background, going back to all the early efforts in your day and mine for national health insurance, and to talk about the implications of these for Black people, and then to come right down and talk about the implications for New York City. And the volume also includes policy papers on what healthcare reform or whatever comes instead of the national reform, because we know there's going to be some action on the state level now that Clinton didn't get his bill passed. What reform will mean for Black children, what are the different views of the bills that were pending a year or so ago, and that they're still in some way being considered nationally. Let's see, what about health, human resources, not manpower. And that's a very important question. You're right here in New York City. Healthcare is the largest employer of Black people, largest private sector employer, nonprofit sector employer of Black people. What's going to happen, for example, if health policy in New York City means that all the hospitals are squeezed and weakened, perhaps, so that they can be eliminated or privatized? What's going to happen to the Black employees? What's going to happen to the health of the Black communities and the brown communities in the city? And another paper was on the whole question of managed care, an effort to bring people into plans that will prescribe limits on services that can be provided as an effort to cut costs, and that may improve quality because there'll be a family doctor helping you get to your care and helping coordinate your way. The problem with that for Black people, of course, is that we don't have very many family doctors in many communities, and the problem.
Although managed care will cause a lot of people who weren't family doctors, family practitioners, to become family practitioners.
Oh, there are a lot of people rushing in big corporations to run these managed care outfits. So that those are some of the issues that that were presented that day. It was a lively discussion, over 350 people there, and it was a day, I think, that helped people do a lot of thinking. The importance of this publication is that now the issues are still before us, and states trying to put managed care into effect for all people on Medicaid. As I said, mayor's trying to reshape the health care system. And the problems that are detailed in this paper of our health are still present.
If anyone in the audience wants to get a copy of this report, Facing Triple Jeopardy, they can contact the Urban Issues Group at 99 Park Avenue, and that's New York 116.
And the telephone number is 212-973-3602.
That's the Urban Issues Group. We also have a newsletter, Urban Scope, which we'll talk about a little later. But before we do that, I wanted to mention a tension that exists. One tension is that as these changes in managed care and better management of health resources come about, the number of employees who are needed shrink. Then the question is, we need that in our community because that causes people to work. But the logical question is, why should you have people working when you don't really need them? And allegedly, the misuse of health resources and health personnel is one of the things that's driven up the cost. I don't know whether that's true or not, but what is your reaction?
Well, costs have gone up for lots of reasons. Costs have gone up because we live in a very litigious society where lots of people sue, where an orthopedic doctor practicing in the city may have to pay $100,000 a year in malpractice insurance, a neurosurgeon even more than that, or an obstetrician around the same amount. So you know if the insurance is that high, then specialists are going to have to charge people quite a bit. Another reason that costs have gone up is that we have all kinds of wonderful, wonderful technology. And technology, you know, I'm not going to criticize it. I have had recent family experiences where technology helped save my husband's life. I know that. I also know he happened to have been in an institution where he got a lot of TLC and the human part of healthcare. And unfortunately, what's happened is that often I teach on the faculty at CUNY Medical School, and I teach at Columbia College of Physicians and Surgery, Columbia University. We need to teach people who are going to be doctors the human side, the art of medicine as well as the science. Because the science of medicine can be very helpful, but is quite expensive. Technological equipment becomes obsolescent very quickly. You have to train people over and over again. That's driven up costs. And then I think that in the 50s, or no, in the 60s, the 70s, and the 80s, when Medicare and Medicaid started, essentially they gave carte blanche to doctors and other healthcare providers to drive up costs. Nobody was paying that much attention to cost control until finally in the mid-70s somebody said, "Oops, let's see what's going to happen." I remember you mentioned my being mental health commissioner. During that time, I was on loan for a while to the Carter administration I directed the task force on the Department of Health, Education, and Welfare, the policy work group. And we were supposed to be recommending, making changes and recommendations, and one of them was, of course, health insurance. But President Carter said it'd be too costly to have it now. Now, of course, the thing is, here we are, everybody knows, the only industrialized country, except for South Africa, that doesn't have a national health program, insurance or some other program. And without that, people just spend and spend till their money is gone, and it's terribly, terribly expensive.
But one of the things that's causing the cutback of health personnel related to our community is the closing of institutions.
That's true.
And that has to do with the duplication of institutions, the duplication of service in institutions. So what do we now say to people in our community? Say, well, look, we're tightening up the healthcare system so that it's less expensive, less costly, but in the meantime, you're going to be out of work. So what's the story
See,
there?
unfortunately, when in the late 70s we had some effort at planning, at health planning, then one would say, all right, we have a Bedpan Row, or right all up and down Park Avenue, and all up in the east side, more duplication in the east side of New York than there is in a Harlem or a Bed-Stuy or Crown Heights.
The allegations we're an international medical center,
Well, may be, but the point is that without real planning, there are going to be duplications because institutions have sprung up over the years. But what ought to be done, in my view, and that of a number of people, is that we need to take this opportunity to reinstitute some planning so that people can be retrained, so that people can be retrained in the skills that are needed for the next century in medicine and in communication and in how to educate people to take care of themselves. There are all kinds of types of knowledge that people need to be retrained to do.
Of course, on the short term, the folks who have the least training are the ones who lose the jobs first, which does relate to some other things that UIG, Urban Issues Group, is doing.
One of our concerns, Dr. Walter Stafford, who is one of our senior research fellows, has been interested in the workforce and has done some previous work on looking at the structure within the city. And one of our ideas is to begin looking at what's going to happen in a number of arenas over the next 2 or 3 years as these economic changes, employment changes go on. things are bad as it is. We're already underemployed as a group of people in New York City. That means there's less likelihood that we have health insurance. We may be scuffling to get some little part-time job which doesn't have insurance. If we do get a little job, it may be we therefore don't have we earn a little too much to be eligible for Medicaid. So there are a number of forces that are going on that we're concerned with. That, the whole area of economics is one we're interested in as an organization, because we still think as a group that we've got to look and see what we can do to help black communities in the city revive. Is there a way that by looking at what some of the economic development that's going on right now in the city, that we can help make that information exchange more useful to people? We've had one symposium this year. One of the things we do besides the research and the publications is to have policy symposia. And we had one on community economic development. And interestingly enough, this was last year, we said that the people who came said, well, they knew that a project was going on in that borough, and they knew something was happening here, but they really never met the people. So we think of ourselves as a convener of bringing people together, and the next step from that is going to be some exchange of information, maybe in a manual or some kind of directory, so that community groups can pick up what's being done in various places to see how applicable it might be to them.
Well, unfortunately, as the federal support for community development and housing decreases, that means we have to turn more to the private sector.
Yeah.
And in the private sector, there has not been a large trend toward African Americans contributing to developing their own businesses.
Yeah.
Now, this is the political end, or the action end, of a think tank.
Yeah.
Now, part of the way in which we get this out is through Urban Scope,
Yeah.
which is the newsletter.
Yes.
And it deals with policy analysis from the perspective of New Yorkers. And particularly, I believe you're going to be doing a study on the state of Black New York.
That's right. That is a long-range project. We hope that report will be out, it's as a book, actually bigger than this monograph, by the end of '96. And it will look at a number of areas which we can talk about. It'll be a monograph coming out, say, every 2 years. Takes a slice of life through New York City. The economics being one aspect particularly. Community institutions that are really struggling to maintain some strength within their neighborhood-based organizations. We're going to be looking at immigration, the effect of moving from one part of the world to another. What does that do to a community? How does it revitalize, affect, influence a community? What impact does urban policy have on immigration and vice versa?
And what about the various subsets of people in the African American community?
Absolutely.
I think with the immigration and the mobility, it's no longer true that most African Americans are from one place or another.
Not at all.
That they're from all over the diaspora with different cultural and economic needs, behaviors.
That's very true. One of the things that we wanted to understand a little bit about was what's the difference between a viewpoint that someone living in Bed-Stuy who's been there maybe for 30 years, who comes from Jamaica, but's been there for a long time, and a person who's come from the South and been there for a while, and a recent person coming from Jamaica. How do they see themselves? How do they see family relationships? How do they see what determines health and illness? So among the people who will be working with us on that is a board member, Dr. Marcia Bain-Smith, whose area of expertise is health education, but specifically she's very much involved in she's president of the Caribbean Women's Health Association.
I think this will help in terms of getting rid of the stereotype of lumping all African Americans together, because just like the white population has Italian and Irish and Germans, with different cultural and behavioral patterns, so does the African American community. I think that's a very useful activity coming out of Urbanitions Group. But let me turn now to your experience as a physician, psychiatrist, health leader. If you were to be talking to me as a young prospective medical student, what would you be saying to me?
Well, I guess I would certainly want to say, Roscoe, I have found this an exciting and gratifying life. I've enjoyed listening to people. I've enjoyed helping. I've enjoyed helping people solve problems. Since I know that you're very good with your hands, I might say to you, all right, what are you interested in? You're interested in surgery. I would probably then have to say, but I want you to know, it looks as though, even though black people and white people still need doctors, some communities need specialists much more than others. The black community needs specialists, black communities in New York City, and they need family care practitioners. However, if you were to go and want to practice in downtown New York, you may have a dime a dozen surgeons. So therefore, what I'm saying is with the changes in the health care and the way health care is financed, it might be, you might not find it as gratifying as I did. Now, I'd hate to have to say that because I really love being a doctor.
Well,
but, you know, some of these limitations and I believe in planning. So, I mean, it's a little, I'm sort of trying to have it both ways.
Well, of course, that's one of the exciting things about what's happening now in healthcare, and also the emerging opportunities for African Americans. No longer does African American have to be a teacher, a minister, or a physician to make a major contribution.
I might even say, as a doctor, you might want to set up a group practice, a health maintenance organization of your own. 10 years ago, there were, you know, HMOs, the health maintenance, the organized system, a group of doctors together. People belong, a panel of doctors, people are enrolled. There were some 40 of these headed by black people throughout the country 10 years ago. Now there are only 7. So I'm troubled by the fact, you know, they took capital and over the years, you know, as things have gotten more difficult for black people throughout the country, even for people who are in fairly good positions, I would say, all right, that may be something you'd think of. I know one thing I might say to you, and that is there's a lot to be learned. You might want to think about.
And you have helped us to learn it.
Okay,
you
next
have
time.
given us a tremendous about June Jackson Christmas, who is the executive director of the Urban Issues Group. Thanks to Dr. Christmas for being with us on today's African American Legends.
Thank you, Rod.